I'm going to explain something to you the way I'd explain it to a patient sitting across from me in my office, because I think the standard, soundbite version of this disease, it causes dry eyes and dry mouth, genuinely undersells what's happening underneath the surface, and I want you to actually understand the mechanism, not just memorize a symptom list. So let's slow down, and let's actually go into the immune system together, because the answer to why is Sjogren's dangerous isn't really about dryness at all. It's about something your immune system starts building, quietly, inside your own glandular tissue, that in a small number of patients, over years, can turn into something far more serious than dry eyes ever were. If you keep leaving appointments remembering symptoms you forgot to mention, I made a Sjogren symptom map to help you track the full pattern. Comment symptom map, and I'll send it to you. Here's the picture most people are given at diagnosis. Your immune system, for reasons we don't fully understand, starts attacking the glands that make tears and saliva. True, as far as it goes. But that description treats the immune attack like a simple, contained event. Cells show up, cause some damage, dryness results, end of story. That's not actually what's happening. What's happening is closer to your immune system building an entire unauthorized training facility inside your own glandular tissue, and that facility doesn't shut down once it's built. It keeps running, indefinitely, and the question of how dangerous your particular case of Sjogren's turns out to be largely comes down to what that facility ends up producing over time. Let me actually build this picture properly, piece by piece, because once you see the whole mechanism, the rest of this disease, the fatigue, the organ involvement, the lymphoma risk, all of it, stops looking like an unrelated grab bag of symptoms and starts looking like the logical downstream consequence of one central process. It starts with your salivary and tear glands getting infiltrated by two types of immune cells, T cells and B cells. Early on, T cells dominate this infiltrate, and the picture looks relatively mild and disorganized, more like a scattered protest than an organized operation. But in a meaningful subset of patients, researchers estimate this happens in roughly 30% of cases, something more structured starts to form. The infiltrating immune cells stop being a disorganized crowd and start organizing themselves into something called an ectopic germinal center. I want you to actually understand what a germinal center is, because this is the single most important structure in this entire explanation. Normally, germinal centers exist in specific, sanctioned locations in your body, your lymph nodes, your spleen, and they're essentially immune training academies. This is where B cells go to get refined, to have their antibody-making abilities fine-tuned and improved against a specific threat, through a process of rapid mutation and selection that, when it works correctly, produces highly specific, highly effective antibodies against things like viruses. It's an elegant, tightly regulated system, normally confined to these specific immune organs, with careful oversight built into the process to weed out cells that go rogue. An ectopic germinal center is exactly that same academy, illegally built somewhere it was never supposed to exist, inside your salivary gland tissue itself. And once it's built, it starts running the exact same training program, except now the threat its B cells are being refined against isn't a virus. It's your own tissue. The oversight and quality control that normally weeds out dangerous, self-reactive cells is far less reliable in this improvised, off-site location than it is in your body's official training facilities. So this rogue academy keeps producing increasingly refined, increasingly specific antibody-making cells aimed at your own body, indefinitely, for as long as the structure persists. If that mental picture just made something click for you, a rogue, unregulated training academy building increasingly specialized weapons against your own tissue, inside your own glands, that's genuinely the core mechanism behind why this disease can behave so differently from person to person. Some patients' immune systems never build much of this structure at all, and their disease genuinely does stay mostly contained to dryness and manageable fatigue for life. Others build a robust, active version of this academy, and that's where the danger in this disease actually concentrates. So what does a fully operational rogue academy actually produce, and why does it matter? Two things, primarily, and both explain a huge amount of what makes this disease genuinely dangerous rather than just uncomfortable. The first product is autoantibodies, specifically the antibodies called anti-SSA and anti-SSB, that show up on the blood work used to diagnose this disease in the first place. But here's what doesn't get explained clearly enough. These antibodies don't just sit quietly in your bloodstream as a diagnostic marker. In a subset of patients, they form what are called immune complexes, clumps of antibody bound to the targets they are attacking, and these complexes circulate through your bloodstream and can physically deposit in blood vessel walls throughout your body. Wherever they deposit, they trigger local inflammation. This is the actual mechanism behind a lot of the extraglandular complications we've covered in other videos on this channel: the joint pain, the skin rashes, and critically, vasculitis, inflammation of blood vessels themselves, which research has identified as one of the single strongest predictors of mortality in this disease. Not dryness. Not fatigue. Vasculitis, arising from this exact immune complex mechanism, is what the data points to as genuinely dangerous. There's a specific blood marker that ties directly into this mechanism and that I think more patients should know about: complement, specifically a component called C4. Complement proteins are part of your immune system's cleanup crew. Among other jobs, they help clear immune complexes out of your circulation before those complexes can deposit somewhere and cause damage. In patients whose rogue academy is producing immune complexes faster than the complement system can clear them, C4 levels in the blood actually drop, because it's being consumed faster than the body can replace it. Research has consistently found that low C4 levels at diagnosis are one of the strongest predictors of who goes on to develop the more dangerous complications of this disease, including lymphoma. It's a genuinely elegant piece of biology, once you see it laid out. A simple blood test, low C4, is essentially telling you the cleanup crew is losing a race against immune complex production that's happening because of that rogue academy we just described. Closely related to this is a specific finding called cryoglobulinemia, antibodies that clump together and become solid, gel-like, specifically when the blood cools below body temperature. This isn't a subtle, incidental lab finding. Research has found that patients who have cryoglobulins detectable at the time of their Sjogren's diagnosis face a meaningfully increased risk of both developing lymphoma and of dying from disease-related causes over the following years, compared to patients without this finding. If your rogue immune academy is productive enough to be generating cryoglobulins, that's a direct signal that its output has crossed into genuinely dangerous territory, not just uncomfortable territory. Now let's talk about the second thing that rogue academy can produce, the one that gives this entire video its title: lymphoma. Here's the mechanistic thread, and I want to walk through it slowly because I think this is the part that gets skipped over in most patient education entirely. Remember, a normal germinal center puts B cells through an intense process of rapid mutation and selection, refining their antibody-making ability. That process, even in a healthy, properly regulated germinal center, inherently carries some risk. It involves your DNA being actively cut, rearranged, and mutated at very high speed, and any process that actively rearranges DNA that quickly carries an inherent risk of something going wrong in that rearrangement. In your body's sanctioned germinal centers, tight regulatory oversight generally catches and eliminates cells where something has gone wrong. In an ectopic germinal center, sitting outside your body's normal regulatory architecture, that oversight is weaker. Combine that weaker oversight with something else: chronic, unrelenting antigenic stimulation. Because the threat driving this rogue academy is your own tissue, and your own tissue never goes away, the stimulating signal driving this entire process never turns off, the way a normal infection eventually clears and lets a normal germinal center wind down. It's less like a training academy responding to a single threat and shutting down once that threat is resolved, and more like a training academy stuck running the same intensive drill on an endless loop, for years, without ever being told to stand down. Years of that unrelenting drill, combined with weaker safety oversight, is exactly the kind of setting where a single cell's DNA rearrangement error can go uncorrected, survive, and begin dividing on its own. That's lymphoma. Specifically, most Sjogren's-associated lymphoma is a subtype called malt lymphoma, arising directly from this exact glandular tissue where the rogue academy has been operating. This is why doctors specifically watch for the warning signs we've covered in other videos: a persistent, firm, one-sided gland swelling, drenching night sweats, unexplained weight loss, because these are the clinical signals that the rogue academy may have finally produced exactly the kind of error this whole mechanism has been quietly capable of producing for years. I want to pause here and give you the actual numbers, because mechanism without context can sound far scarier than the reality warrants. Lymphoma develops in somewhere between about 3 and 10% of Sjogren's patients, depending on which study and which population you look at. That means the overwhelming majority of patients, the ones whose rogue academy either never fully forms, or forms but never crosses into malignant territory, never experienced this specific danger at all. The mechanism I just walked you through explains why the risk exists and why it concentrates in a specific subset of patients. It does not mean this outcome is common, or that it's coming for every person with this diagnosis. Let's talk about why all of this actually matters for how doctors approach treatment, because understanding the mechanism changes the entire logic of management, not just the symptom list. If the danger in this disease is genuinely concentrated in this rogue immune academy and what it produces, rather than in the dryness itself, that reframes what good management actually means. Aggressively treating dry eyes and dry mouth, while genuinely important for quality of life, isn't targeting the mechanism that actually drives the dangerous complications. That's part of why current research increasingly focuses on markers like the ones we just discussed: low C4, cryoglobulins, the presence of ectopic germinal centers on biopsy, as a way to identify which patients actually have an active, productive rogue academy running, versus which patients have a much quieter, lower-risk version of this disease. This is precisely the kind of risk stratification modern rheumatology is trying to get better at, not treating every Sjogren's patient identically, but identifying, as early as possible, who's carrying the biological signature associated with genuine danger, and directing closer monitoring and more aggressive treatment specifically toward that group. I also want to explain, mechanistically, why the extraglandular symptoms we've covered elsewhere on this channel, the neuropathy, the kidney involvement, the lung involvement, aren't a separate, unrelated story from everything we've just discussed. They largely trace back to the same two mechanisms, either direct lymphocytic infiltration of that specific organ, the same process happening in the salivary glands happening instead in, say, the kidney's tubules, or immune complex deposition in blood vessels supplying that organ, the same cryoglobulin and complement story we just walked through, simply playing out in a different location in the body. Once you understand these two mechanisms, nearly every complication of this disease stops looking like a random new problem and starts looking like the same underlying process, showing up in a new address. Let me bring this back to something practical, because I don't want to leave you with just an anatomy lesson. If you have Sjogren's, there are a few pieces of this mechanism worth actually asking your rheumatologist about directly, because they translate into real, actionable monitoring. Ask whether your complement levels, specifically C4, have been checked as part of your workup. Ask whether cryoglobulins have ever been tested for. Ask whether you've had any extraglandular symptoms, joint pain, skin changes, kidney function changes, that might reflect this immune complex mechanism actively at work, rather than being separate, unrelated complaints. These aren't abstract academic questions. They are the specific, concrete markers research has identified as meaningfully predicting who's carrying higher risk, and knowing your own numbers is genuinely more useful than knowing the general population statistics we've been discussing. I want to address something directly, because I think it's the single most common misunderstanding this mechanism explanation clears up. Patients often ask why their blood work can look relatively unremarkable while they feel absolutely terrible, or conversely, why someone else's labs look concerning while they feel comparatively fine. The rogue academy mechanism explains this disconnect well. Glandular symptoms, the dryness, a huge amount of the fatigue, largely reflect direct, local tissue damage from ongoing lymphocytic infiltration, which doesn't necessarily track closely with how productive or dangerous that ectopic germinal center structure has become. Meanwhile, the markers that predict genuine systemic danger, C4, cryoglobulins, extraglandular immune complex deposition, can be quietly abnormal in someone whose day-to-day dryness symptoms are actually fairly mild. Severity of daily symptoms and severity of underlying immunological risk are related, but they are not the same measurement, and conflating the two is one of the more common sources of confusion I see in my own patients. Let's talk about why this disease has historically been called benign in comparison to something like lupus, because I think that comparison, while statistically defensible, has done this disease's public understanding a real disservice. It's true that, compared to lupus, a smaller proportion of Sjogren's patients develop severe, immediately organ-threatening disease. But smaller proportion is not the same as zero, and the mechanism we've just spent this entire explanation walking through is every bit as real, every bit as biologically serious, as anything driving lupus's more frequently severe presentation. The rogue germinal center, the immune complex deposition, the lymphoma pathway, none of that is a watered-down, lesser version of autoimmune disease. It's a genuinely dangerous mechanism that simply happens to fully activate in a smaller percentage of the people who carry this diagnosis. Calling the disease itself benign, because most cases don't reach that endpoint, risks minimizing the exact biological process that makes the minority of cases genuinely dangerous, and I think patients deserve the more precise, more accurate framing instead. So, why is Sjogren's dangerous? Not because dry eyes and dry mouth are inherently life-threatening, they are not. It's dangerous because, in a meaningful subset of patients, the immune system doesn't just attack glandular tissue and stop there. It builds a persistent, poorly regulated structure inside that tissue, one capable of two genuinely serious outputs over time: immune complexes that deposit throughout the body and drive some of this disease's most dangerous complications, and, in the exact same structure, the raw biological conditions under which lymphoma can eventually arise. That's the real answer. Not a vague "your immune system attacks itself." A specific, identifiable, increasingly well-understood mechanism, concentrated in a subset of patients, that modern rheumatology is getting better at identifying and monitoring with every passing year of research. If this changed how you understand your own diagnosis, or gave you specific questions worth bringing to your next rheumatology appointment, the C4 level, the cryoglobulin test, whether extraglandular symptoms are being tracked, I genuinely encourage you to write those down before you forget them. Understanding the mechanism doesn't just satisfy curiosity. It gives you the specific vocabulary to have a much more precise, much more useful conversation with the person managing your care. And if you want to understand how this mechanism connects to the specific complications we've covered elsewhere on this channel, the 20 body parts this disease can reach, or the specific warning signs worth knowing as a family, those videos will make considerably more sense now that you understand the Rogue Academy sitting underneath all of it. Type mechanism in the comments if this is the kind of deeper, "why does this actually happen" explanation you want more of, because that tells me exactly what to build next. Understanding your own disease, at this level of detail, isn't just interesting. It's one of the most genuinely useful things you can do for yourself as a patient. I'll see you in the next one.